And not as nice as yours or as Vinko or Shige. And thank you very much for your masterful series that you've been putting together and bringing all these giants to teach everybody, and your audience numbers show it. So you and Vladimir, we all owe you a debt really for doing this. Wonderful to see you, Vinko and Shige, and the rest of the speakers. So how do we honor Roten in 15 minutes? So I thought I'll talk about this topic, which was really very close to him. Skull base and cerebrovascular are really two animals of the same cloth. This is where Al was born, a cabin in Parvin, Kentucky. It is amazing that to go from there to having photos and instruments represent who you are. Very few neurosurgeons in the world today, you can put their work product without their name and recognize who they are. With Al Roten, you do and you did, exactly as Imad introduced him earlier. He was a wonderful family man, and this is his slide. Who among you would write a slide like this? Microsurgical anatomy is delicate, faithful, awesome, accurate, gentle, and safe. Who among us uses words like this on a daily basis? Very few. He has introduced humanity into neurosurgery. Of course, I am not one of his immediate trainees, but I've been honored to be on the board of the Roten Society, which Shige was a president of, and now Matsushima. Just you can see the love of everybody that he has touched. He is really a child, a scientist, and a saint, all in one person. And just very few people are really like this, certainly among neurosurgeons. You want to list his qualities? I think I've chosen 10. You can read them for yourselves. And again, very rare to see that conglomerate of qualities in one person. When he died, I had just become president of the North American Society, and I wrote his eulogy, and it's published. If you're interested in seeing what my thoughts are about this unique man, you can look it up. It's back in 2016. Are cerebrovascular surgery and skull-base surgery inseparable twins because they want to be inseparable, or because they have to? So I'm going to conclude my talk later by telling you it's because they have to. So these are two boxes. The yellow box is skull-base, the red box is vascular. You can see some of the names of neurosurgeons that chose to be vascular pure or skull-base pure, but the ones in the middle chose to be masters at both. Please notice the box of endonasal endoscopy. It crosses a little bit into vascular. Some endonasal endoscopists do vascular work. No pure endovascular neurosurgeon generally does skull-base work. It's a call of the anatomy. It is a symbiosis, vascular and skull-base. You can see all the intersecting circles, the disciplines that encroach on those, not encroach, that are symbiotic with those two disciplines. But my point today in the talk is that area number 2 is very important. Why? Because cerebrovascular helps skull-base. Examples are ICA balloon test occlusion for tumors, pre-op tumor embolization, intra-op repair of injured arteries or veins during tumor resection, the microvascular skills that you acquire in dissecting, manipulating, and respecting the brain. The other way around as well. Skull-base helps cerebrovascular. Why? Through the Roten's anatomy, appreciation of anatomy, surgical exposure. When do you need that much exposure? What is just enough? What is not enough? And what is truly unnecessary as an exposure? And then you have your toolbox of all the approaches in skull-base to tailor to the vascular pathologies. And you know, when you think of vascular and skull-base open surgeons, I mean, they are very similar in character if they're not the same person. And these are some of the qualities that came to my mind thinking of you know, the big masters in skull base and or cerebrovascular, stamina and creativity and mental focus and so much. So I will submit to you that they are inseparable. So the rest of the talk, I'm going to show you simply case examples of how vascular helps skull base and how skull base helps vascular. Anytime something is written in red, it's cerebrovascular, and it's in yellow, it's skull base. So let's show you an extreme transodontoid approach for basilar invagination with transposition of V3. This is a case irreducible. My spine colleagues, I'm not a spine person, told me that a posterior fusion would not fix this man. He was fixed and he had myelopathy. So I normally do these odontoidectomy endonasally, but his carotids were very close together at the nasopharynx. And we even did the laryngoscopy and documented that indeed you can see the carotids pulsating and almost kissing in the midline. So I decided that that's not safe to go endonasally. So here we are, left far lateral, exposed V3 segment, section C2 nerve root, dorsal ramus, expose the proximal V3, expose tip of C1. We are using a Colorado needle, drill the transverse process of C1, unlock the transverse process, cut the fascia over the VA, translocate V3 segment of the artery medially, you can see it here, then do lateral mass drilling of the also occiput C1 joint, and that takes you all the way to the odontoid, which we drilled and cut the contralateral transverse ligament, and that's and fusion of the patient, and we've relieved the myelopathy, and you can see the post-op bottom left, how far you can go with that transodontoid approach, the post-op on your right. So had I not been comfortable handling the vertebral artery, I could not have done this case, it's clear. Vinco has taught all of us how to handle the cavernous sinus, and Atul Goel is on the list here today, and Atul has the largest experience with operating on these horrific lesions, the cavernous sinus hemangiomas. And unless you know how to handle the vascular supply intraoperatively, you cannot do these cases. So here is clinoidectomy extradurally, and then the Dolenk peeling of on top of the lesion. The biggest mistake would be to enter the lesion right now. You don't want to do that. You want to surround your enemy before you attack it, and be comfortable with the coagulation, mapping of the nerves in the cavernous sinus, coagulating, finding on purpose the carotid artery in the cavernous sinus. You can use a Doppler to do it. And then when you've done that and you have controlled the perimeter of your tumor, then you go intradurally, you coagulate. Look, the lesion is becoming blue because the blood supply is dying. Now the enemy is ready to be attacked. And then you will still have bleeding, but it will be very tolerable bleeding. By the time we finished, we're putting some Eviseal tissue sealant. Here is the cavernous sinus with the nerves working between all the triangles, again, that Vinco has taught us so many years ago. There is a post-op MRI, complete resection of those lesions. Sometimes you have to do cavernous sinus exenteration to deal with tumors, on purpose sacrifice some structures. Such an example is this unfortunate woman with a WHO grade 2 meningioma. Look at the list of surgeries she has had elsewhere and with me over the years, radiation, cyberknife, and within few months, she developed cavernous sinus ophthalmoparesis, third nerve, which you just saw. This tumor had grown like 4 times in 6 months. Look how it's enveloping the supraclinoid carotid, the cavernous carotid, the cavernous sinus invasion. young woman, I told her, we've tried everything. I am going to exenterate your cavernous sinus. I'm going to resect your carotid artery, including the anterior choroidal artery. I am sure I will not be able to save it. I will unquestionably give you a stroke, but I think you're going to die if I don't try it. Are you willing to go ahead? And she was. I am not going to show you the entire surgery, but just to show you the handling of the cavernous carotid. It's easy here, of course. We're going in to sacrifice it, not to preserve it. We had done a balloon test occlusion, and it's a matter of, you can see the clips. So, you know, a skull-based surgeon needs to know how to handle aneurysm clips, needs to know how to handle carotid. Here is the ascending cavernous carotid. Very nice view of the sympathetic plexus around it. Clipping it and so forth. Again, it's not, the details are not important, it's just the concept. So here I am now cutting, you can see the clip below M1 and A1 bifurcation, including a sacrifice of the anterior choroidal artery. But I did resect the tumor completely. I drilled the posterior clinoid. What I want to show you is the stroke that I knew I was going to give her at the end. Fat graft here. Here is post-op fat graft, and the stroke that she had is this. Amazingly, she recovered within 4 months. This woman lived another 6 years and then died of another recurrence. But I think she would have died that year had I not done something like that. I want to catch up on time. So if you allow me, Imad, how many minutes do I have? I cannot hear you. If you
still have 10 minutes.
I have 10 minutes. Okay.
Yes.
Thank you. Injuring the carotid artery during transsphenoidal procedure. My team has done 2 of these over the last 20 years. I want to show you this one from 2013. Recurrent pituitary adenoma. You can see, look at the right carotid artery, rather medial. And during the endonasal approach, my very talented rhinologist decided to use the pineapple sonopet, which is really not meant for drilling the bone because it's meant for coring bone. And you will see in a second, as he uses it, the carotid will blow out in his face. This design is meant for thick bone. If you want to use, you can use the claw of the design, the claw tip, or you can use the diamond drill bit. But please don't use this. You see the carotid on your left? Unfortunately, disaster is about to hit. And it'll hit so hard, you actually won't see the injury because blood will fill the endoscope camera. There you go. You can't see anything. So what do? Of course, it's transsphenoidal. It's not intracranial. You pack it, and of course, torrential bleeding. The point is, I'm not showing you this just to show you exciting bleeding, but if you don't understand vascular and you're doing skull base, that's a problem. So we pack it, and we go to the angio suite. And I'm going to show you the team approach between the endonasal endoscopist and my colleague endovascular. The packing occluded the carotid. So you take the tower, the endoscopic tower on the left, you can see it. So as the rhinologist is removing the packing, my endovascular colleague, Ali Sultan, is advancing the coils. So it was like a ballet. Again, luckily, the patient tolerated this carotid artery sacrifice, and I took the patient back to the OR. You can see the carotid with the tail of coil sticking through the hole, and I completed the tumor resection. Cerebrovascular at the service of skull base. How do you handle veins in some skull base procedures? Well, when you injure veins, you need to try to repair them. This is an example of one of my residents opening a retrosigmoid on an acoustic neuroma and tearing the sigmoid sinus. You can see it with the drill. Well, don't give up on it. Don't just pack it, and you can, if you know how to suture a vein or an artery, you drill a little more and you repair the sigmoid sinus instead of starting an acoustic neuroma surgery with an occluded vein and causing cerebellar swelling. And of course, veins are much easier to suture than arteries. You can use the parachute technique, which is temporary packing. You put your loose running suture and then you pull the two ends like this and don't over tighten, and that's it. And that really simple. Another case of a recurrent jugular foramen schwannoma. During the redo, during the opening, again, the vein of Labé was torn. Look how the brain was bruised during the opening. And this is the vein of Labé. I come in and I'm trying to figure out, can I salvage this vein? I have two ends of vein of Labé. Don't bipolar it, suture it together, end to end. Luckily, I was able to have enough length to do it. Otherwise, I probably would have taken a small vein and grafted end to end. So reopening the vein, there you go. And then again, very simple matter to do an end-to-end anastomosis. Again, if you're not facile with these techniques and you're doing a complex skull-based surgery, how are you going to deal with this? So here you go. And then we proceed with the surgery after that, with the tumor resection. And this temporal lobe edema, I submit to you, would have been worse had I not repaired the vein of Labé. Now, how does skull base help cerebrovascular? Many ways. I will absolutely not have time to discuss all of them. Aneurysms, as Vinco opened the door for these paraclinoid aneurysms. Yazargil himself said he had no idea how to clip them. This is one example. Dural AV fistula, brainstem cavernomas. I'm going to skip superior hypophyseal artery aneurysm clipping, which of course Vinco taught us how to have a view like this when you clip with a fenestrated clip after drilling the clinoid. How would you do that without understanding skull base? In the current days of endovascular, of course, basilar tip giant aneurysms like this one kept recurring, stent, coiled, recurred. It's like a malignant tumor. Came to me last year. What did I do? Transcavernous approach to clip it. This is, again, no time to show the whole thing, but this is an anterior clinoidectomy. What is it that we need to understand? We need to understand the anatomy of the cavernous sinus. Here I am peeling the oculomotor triangle. This is drilling the anterior clinoid, skeletonizing third nerve and fourth nerve, cutting the petroclinoid ligament, moving posteriorly. These steps we did not understand, again, until Vinco and of course Roten created as well the beautiful anatomy. Here is a posterior clinoid. You can see the ugly coiled aneurysm. And what I'm going to end up doing is cutting into the aneurysm and clip reconstructing, cutting through the coils, cutting the PCOM, which is in my way. Here is PCOM cutting. And I'm not going to show you the series of clips, but I ended up clipping it with a very good result. Here is the post-op angiogram. Couldn't have seen this without drilling the cavernous sinus. I think I should reach my conclusion. I'll skip several other cases to show brainstem cavernomas, doing far lateral approach, Kawase approach, and so forth. Some twins are meant to be separated, some are not. And I think skull base and cerebrovascular surgery are such. My conclusions about Roten: the Roten legacy is thriving around the globe with societies like the Roten Society. It is a self-generating cycle of mentorship to mastery and mastery to mentorship. It's art and surgical skill intertwined. Skull base and vascular are intertwined. And to the young people in the audience, there is no such thing as talent. Deliberate practice beats talent every time. Go to the lab, and go to courses. Thank you very much.
Thank you very much for being on time, Jacques.